Good afternoon in Africa, good morning in the United States, and welcome to our monthly Africa-U.S. forum. Actually, this is our second one for this month. Our initial African perceptions on and responses, perceptions of and responses to reductions in foreign aid for health and medicine. This forum is on the record and is being recorded. Video will be available on demand later on the USC Africa-U.S. website, where you can find videos of all of these forums. Our next forum will be on Monday, May 5th, African Views of World Press Freedom Day. Actually, Press Freedom Day this year falls on Sunday the 4th, but we're going to mark it on Monday the 5th. We have speakers from across the continent joining us today. Each will be introduced in turn, and as each one speaks, we will put into chat their biographies. For those who are online, you will see that as each speaker joins us with remarks. These monthly forums are presented by, in alphabetical order, the African Center for the Study of the United States at the University of Witwatersrand in Johannesburg, the Annenberg Center for Communication, Leadership, and Policy at the University of Southern California, the Center for African Studies at Howard University, the Institute for African Studies at George Washington University, the Institute on Inequalities in Global Health at the University of Southern California Keck School of Medicine, and the Public Diplomacy Council of America. Today's topic is timely and critical. Over the weekend, the Financial Times summarized what is happening in 4 chilling sentences. Not only has the United States shut down USAID and the UK slashed development aid by more than half, but there have been cuts to the French, Belgian, and Dutch budgets. The latest warnings come from Berlin, where the new coalition has put the development budget on the chopping block. In the worst-case scenario, global aid budgets could be slashed by a staggering $74 billion in 2025 alone. That would be 30% or so of total overseas development assistance. So America and Europe seem to be turning away from the global South. So let's hear from African experts what that's like from Africa. And we begin, as always, by going to our co-convener, Bob Wekesa, the director of the African Center for the Study of the United States at the University of Witwatersrand in Johannesburg. Bob.
Thank you very much, Adam, and thanks all the colleagues for joining us today. My very brief remarks as we launch into this discussion today is that we established the Africa-U.S. initiative as a partnership that Adam has outlined. In December of 2022, those were very optimistic times. The U.S. Under President Biden hosted the U.S.-Africa Leaders Summit, and there were a lot of progressive partnerships discussions on how the relationship between Africa and the U.S. could be ramped up. And in the subsequent years, we saw quite a bit of lots of charting the way forward on Africa-U.S. partnerships and so forth. So as partners, we thought we would be of relevance in the discussions, in the debates, by undertaking monthly forums. And so up to this point in time, we are coming very close to 30 such monthly events. As fate will have it, beginning January 20th, there was an oath of office in Washington, D.C., and we became even more relevant, albeit in very tough circumstances. And it's for this reason that we have had to rejig, to rework, to reorganize our thoughts and ideas to really focus on the impact of the new direction, the sea change in the America First policy and its implications for Africa. So we look forward to these discussions, and we are not treating them lightly. We want to generate knowledge that can help us understand and also plan and look at way forward on Africa-U.S. relations. And so we welcome you to today's session and the sessions that will follow, and hoping that we can have a good discussion with all of us. I think those are my welcome remarks, and over to you, Jonathan.
Thank you, Bob. Thank you, Adam. Good morning and good afternoon, everyone. My name is Jonathan Cohen. I am a professor of clinical population and public health sciences at the University of Southern California Keck School of Medicine, and also the director of policy engagement with the USC Institute on Inequalities in Global Health, which has the great privilege of co-sponsoring this first in a four-part series on the future of Africa-U.S. health diplomacy, along with the USC Annenberg Center for Communications Leadership and Policy, and the African Center for the Study of the United States and our co-partners. I really want to underscore what a privilege it is to reach this distinguished audience with messages from Africa about the implications of the mass reduction in U.S. foreign assistance for public health in Africa. This is obviously an issue that has garnered widespread attention in the last couple of months, but a lot of this attention has situated the executive orders within issues of American democracy, American foreign policy, politics, and the rule of law in the United States, which are, of course, important issues. This session is a unique opportunity to hear from a diverse range of African voices about how Africans are reacting to this change. And I think some of what you will hear will surprise you. Some of it may not, but I am certain that some of it will. I will take a moment later to introduce the three panelists that we've invited to speak. But before I do that, I'm going to turn it back to you, Bob, and to your colleague, Job Allan Wefwafwa, to give us some preliminary findings from a data analysis of what African media and thought leaders are saying about this reduction in global health assistance and foreign aid. So just to take a moment to introduce Allan Wefwafwa, who will be joining Bob Wekesa for this opening presentation. We'll put his bio into the chat, so I won't read the whole thing. But Allan is a lecturer specializing in social media and African electoral politics. He is currently teaching at both the University of the Witwatersrand in Johannesburg, as well as the Technical University of Kenya. Allan, we're very pleased to have you join us along with Bob, and I will turn it back to you to frame today's panel with your preliminary analysis. Thank you.
Thanks very much, Jonathan. Our presentation is divided into two. I'm starting off, then my colleague Allan will follow. And as mentioned by Jonathan, we thought that very structured approach to researching and producing knowledge on the current health diplomacy issue based on the America First policy and its implications for Africa will be good in terms of really surfacing nuanced, data-driven, evidence-driven perspectives on views from Africa. And that gets us very close to public perceptions of the issue. I'll also start by noting that last week we had an event that was rather comprehensive, not necessarily focused on the health and medicine domain. And we got quite some interesting perspectives, not least from our audience, but also from the speakers. One speaker noted that this was actually a silver lining. It was an opportunity for Africans to be self-reliant, to take this as an opportunity and to start perhaps rethinking the dependence on external partners. Another speaker observed a very ironical development here. And he was speaking about the gutting of the Voice of America. And he pointed out that even as Voice of America was disappearing from the scene, there was an executive order that kind of suggested that freedom of expression will actually mean anybody saying anything, which takes us into the domain of misinformation and disinformation, which of course then also plays out quite a bit in the health domain. Another of our speaker indeed talked of the possibility of other actors filling the space that the US is living as it goes isolationist. And this is pretty much in a multipolar world where Africa is, of course, next to the Gulf states that are heavily invested on the continent. The big one is China, which plays quite a big role in health diplomacy. And of course, we understand health diplomacy as essentially the shaping of relations, negotiations, be they formal or informal, in the health, medicine, and well-being kind of domains. Our research is based on a theory called media framing. Now, I'll not take you through the pedantic, abstract ideas of media framing, but media framing is basically very close to what journalists in the House and communicators and others will understand as agenda setting, meaning that the executive orders and executive actions have a cause and effect dimension. They are issued from one side, that is Washington, D.C., but they are received, processed, and responded to in a different way. And so to do that, we are approaching this by collecting data from databases, representing all English-speaking language newspapers online, of course, from around the continent. We would then want to segment those into implications or responses from country by country in the 5 regions of the continent. There are various issues that emerge from there, and of course, continentally. The questions we are asking is, how are African actors responding? And these African actors might be opinion shapers, they might be leaders, they might be citizens, everyday people, and so forth. And what are the implications for the US itself in these current circumstances? And what are the plans going forward on the basis of what we are learning? Basically, the 4 frames that we are using is one, the morality frame, which is basically the emotive frame. You know, when the media coverage kind of attributes morality or lack thereof to certain leaders that are taking certain action. We are also using the impact or consequence frame, which has been heavily cited. The people who are going to be heavily impacted in various forms and shapes. We are also using the conflict frames, where we look at the differences or the clash in approach between African actors and their counterparts. And lastly, we are using the responsibility frame, where we look at how media covers this unfolding story from the point of who is responsible here. Is it the US or African end of things? And I think with those few remarks in terms of methodology and so forth, I'll turn it over to my colleague, Allan Wefwafwa. And as mentioned by Jonathan, this is really very preliminary results. We hope to release the entire report later as we go on. So over to you, Allan. Thank you.
Thank you, Bob. So just straight on, the preliminary findings indicate that most African countries from the 5 regions Bob mentions have coverage in the media where impact is most prominent. They cover the impact of the stoppage of US aid on health. And then the second most is the responsibility, then there is conflict. The interesting aspect here is that we have not yet seen the aspect of morality. And this points to the view that the African point of view is that the US is not to blame for the stoppage. the African people would possibly want to take responsibility of their own health. And this possibly again points to the neo-colonial relationships in which it's not clear who decided the US aid to come to Africa, for instance. The African received it, but who decided that? Maybe the African would have decided something else, be it in the 1940s, something after Second World War when it began. And so that's an interesting preliminary finding, though the weakness here is that we intend to have more newspapers, possibly over 100. Well, we are over 50, moving on, but still the pattern shows that the impact and responsibility are more covered. And so far, okay, there is some little conflict there, but there is no aspect of morality. There's no aspect of blaming the US for the stoppage. And another aspect that is coming out clearly is the idea of the European media covering that aspect in Africa. And so we were not decisive on whether we should categorize that as African media coverage. Something like DW, Deutsche Welle for Germany, Reuters, AP, they are stationed in Africa and they cover these stories. So should we view them as African coverage, or is it a neo-colonial interest being advanced? And so there is that perspective, and they feature quite prominently in some countries more than the local newspapers in there. And so that's another pattern that is emerging. And of the 5 regions Bob mentions, the least covered, the region that covered least on the US aid stoppage was the Northern Africa. And that could be because they did not receive much of the aid, possibly, or they are non-English speaking countries. And so our methodology could not capture the Francophone and the Arabic speaking, even though they may have covered, and that turned out to be a great weakness to our approach to the research. And so, yeah, the French countries are very many in Africa, we noticed that. And so as we dwell on the English speaking, there may be almost half of the data that we could be missing out, though we have not figured out on how we can compensate on that. And so I think that kind of shows a pattern very preliminarily on what we intend to do. Yeah.
Thanks, Allan. Let me round off this discussion before handing over back to Jonathan and just say, one of the other things that we are finding is the focus in terms of disease burden in the various regions of the continent. Southern Africa is matters to do with HIV/AIDS, very prominent. Central Africa, where the DRC is, parts of Uganda, there are concerns about Ebola as a unique aspect there. There's also discussions bringing in the COVID-19 experience and the Ebola disease, particularly in parts of West Africa. But I think at this point, we've just shared the preliminary results. We will hand over to Jonathan and promise that we'll provide a fuller report subsequently.
Oh.
Thank you. Yeah.
Perhaps if you have some 10 more seconds, I could add on something you've reminded
Jonathan,
me.
yeah.
Allan, you wanted to add something?
Just 10 seconds, yeah, to bring out the view that while we see this as an aspect of the impact on Africa, actually it is interesting that in South Africa, research on COVID virus, for instance, has been advanced, and this affects the globe, not just South Africa, but it has to be put on hold because of the US aid stoppage. And so that has a global impact beyond Africa. So while we are looking at Africa, some of the impacts are far beyond Africa. Yeah, thank you.
Thank you, Allan, and thank you, Bob. Really appreciate the preliminary framing. I think the two themes that you identified of impact and responsibility frame the discussion very well. And we're very fortunate that all three of our panelists are here to elaborate on those and more. So I'll ask our panelists to please turn your cameras on. I'll introduce you quickly. We are joined for our panel by Dr. Danjuma Adda. First of all, Dr. Adda is an accomplished public health expert from Nigeria with a background in microbiology, with more than 15 years of experience in public health and advocacy, and is a leading voice in raising awareness about hepatitis, including in his capacity as past president of the World Hepatitis Alliance, the first African to hold that post. Welcome, Danjuma Adda. We're also joined by Mia Malan from South Africa. Mia Malan is the founder and the editor-in-chief of the Bhekisisa Center for Health Journalism. She has worked in newsrooms in Johannesburg, Nairobi, and Washington, D.C., has won more than 30 awards for her print and broadcasting work, and she and Bhekisisa have deeply covered the stoppage of foreign aid, and her full bio will also be added to the chat. And we are also fortunate to be joined by Beatrice Were. Beatrice Were from Uganda is a co-founder of the National Community of Women Living with HIV/AIDS, which she co-founded in 1993 to unite and improve the lives of Ugandan women affected by HIV. She is a prominent AIDS activist, renowned for her dedication to the rights of people living with HIV, has won multiple honors for her work, including the Interaction Humanitarian Award and the Human Rights Watch Human Rights Defender Award, and her full bio will also be put in the chat. So welcome, Beatrice, welcome, Mia, welcome, Danjuma. I'd like to begin with a question for all three of you, and I'll start with you, Danjuma, and then we'll move to Beatrice and then Mia. So we've just heard a preliminary framing of African media coverage of the US funding stoppage. One of the themes that we heard coming out of that related to the impact of the stoppage on Africans. I'd like to ask each of you to elaborate on that, please. In your communities, who is at the biggest risk of health impacts of this stoppage? Who do you think will hurt the most? Danjuma, let's start with you.
Thank you, Jonathan, and good afternoon from Nigeria. Thanks a lot for giving me this platform and the invitation to be here. So, Jonathan, in addition to my background, I would say that I'm also an individual diagnosed with hepatitis B. So I'm a patient, and I'm someone who lives on antiretroviral and someone who has to go to the hospital regularly to check my liver enzymes and to check my conditions, right? To ensure I don't develop liver cancer. So the most affected are the poorest of the poor, the underserved populations. I live in a community of a state of over 3 million people, and majority of these folks are people who get healthcare services in secondary and suboptimal primary healthcare centers, right? And majority of these folks are people without health insurance, people without who do not should I say, access services in the private, much more enhanced healthcare services. So The people most affected are patients, people with lived condition, people diagnosed, and that depends on the enhanced public health systems that the foreign aids have developed, have strengthened. Supply chains, people that benefit from antiretrovirals, right? Patients whose life depends on that and whose life depends on diagnostics, for that go to the hospital to run tests, and all this with the foreign aid no longer there. I'm afraid what becomes of patients like me and people who would need to be, especially, patients that live in the public health sector, public health systems, not the private. The private, majority of people who access healthcare service in the private are most likely the rich and, people who have the money to fly to the US or to fly to any Western country to buy healthcare services. So displaced populations, refugees, key populations, sex workers, children, adolescents, people who rely on the public health systems where the foreign aids have developed these systems are individuals that will definitely suffer and will have the brunt of these challenges. Like I mentioned, someone like me or patients like me need to go to the hospital frequently. And with these systems, with the foreign aid no longer there, antiretrovirals, diagnosis systems, the clinical assistance and everything is disrupted. So communities and patients, the poorest of the poor, the last patient in the last mile are the people that are most affected. And these are the individuals we need to protect. Thank you, Jonathan. Over from you from now.
Thanks, Danjuma. Beatrice, over to you. Who did you first think of when you heard about this in terms of who in your community will hurt the most?
Thank you, Jonathan. And thank you for organizing this. And for fellow panelists, thank you for joining. Coming from Uganda and working in Africa, and for the years that I've been doing this work as an activist, I will tell you immediately that the people that will be affected most are the women. And across the, like the disease burden, but in specific reference to the US funding and US aid and the freeze, it is basically we look at women as women as the carriers of the burden of care, taking care of the patients of the 3 diseases mostly that were affected most. That's HIV, tuberculosis, and malaria, which are the big burden for most of our countries in Africa. And using Uganda as a reference point, which I know is not different from other countries in Africa, I will tell you immediately that that burden is eminent on women. The other thing that needs to be raised here is also the fact that there was no notice that the withdrawal of this support did not allow for transition. So there was no preparedness. It was an abrupt thing. And to win us off in such, to abruptly stop this funding meant immediately these communities that are going through this stress, as Danjuma mentioned, had to survive on their own. And as it is now, communities are left struggling. And the women mostly, because we know from the statistics that women are most affected. The highest infections happen in women, and this has been for years, and science has shown us the reasons why. And these are the very communities that are struggling with other issues of human rights, issues of gender-based violence, different challenges that they are facing, climate change. All these are weighing on these vulnerable communities. And to withdraw funding in such an abrupt manner, it's to me, it's so much cruelty. And I want to say, we are not saying that our governments do not have an obligation towards our citizens, but the fact that this was a commitment to saving lives, and then you abruptly withdraw from these very communities that have been sustained for all these years without thinking about the impact, the consequences. It is very painful, I will say. The other thing is to mention the fact that the communities that are criminalized by law, like in Uganda, the communities that are criminalized, the women, like the sex workers, the LGBT communities, those are the communities that immediately felt the shocks because the services that they depended on were funded by the US government. The clinics where they went, the drop-in centers where they felt safe have all been closed. So nobody is following up to know where these individuals are going because of the stigma and the fear, and they are worrying by themselves. Support services like counseling and the support groups have all been disintegrated. So there is no support whatsoever. When you look at, again, issues of disability, and I will be biased to talk about women. When you look at disability in general and the role that women hold, you can imagine for a disabled woman who has been getting these services closer to her community, now having to travel miles to the government health centers, where because right now in Uganda, there is that services are now integrated, that you have to travel to a health center. So for a woman who is disabled, who is facing a lot of stigma because of having HIV and tuberculosis and has got to travel all these kilometers to access services, it is such a burden. And most likely when they get there, the medication is not there anyway. And the place is so crowded and being exposed to other infections like TB, COVID. And in Uganda, we have had an outbreak of Ebola right now as we speak. That is also another challenge that the country is struggling with. So it is these communities that are voiceless, the communities that have depended on these services for their livelihoods and their survival, that are affected most. And it is the very communities that are actually speaking out. You will hear very little from governments. You will not hear that voice coming out to respond or to protect or to even propose what can be done at this time. So the very communities that are traumatized are the voices that are coming out to make all the appeals, to do different things, to try and engage duty bearers where we are not seeing any results until now. So Jonathan, I'll leave it, I'll give it back to you. I'll stop here so that I allow other people also to contribute. Thank you.
Thank you, Beatrice. I think we're getting a very vivid sense from you and Danjuma of how the burden of this aid stoppage is not experienced equally by Africans, and that the impact truly is dependent on people's unique circumstances. Mia Malan, you and your colleagues are responsible for much of the African media coverage. What are you seeing in terms of specific impacts and communities that will suffer the most?
Yes, thanks very much, Jonathan. So if you look at South Africa in the way that PEPFAR's programs worked here, they worked in half of our health districts. We've got 52 health districts, and they worked in 27 of them where the HIV burden was the highest. And they specifically focused on key populations. So if you ask me who's worst affected in South Africa, it would be key populations. So sex workers, LGBTI people, injecting drug users, but the largest part of our key populations are actually young African women between the ages of 15 and 24. They're the group who acquire HIV at the fastest rate in not just South Africa, but in the entire Southern and Eastern Africa. So our situation is a little bit different from other African countries. The government buys 90% of our ARVs, and the rest of it we get from the Global Fund. So PEPFAR ending programs didn't affect the medication that we get, but it affected severely how to get that medication to people, because they funded NGOs that were responsible to get medicine to key populations in an easy to find way. So they were the people who would have community health workers, and they would go to communities so that people didn't have to go to clinics, and they could get it from a community hall or a church or a mosque. And they were the people who would go and find adherence counselors, the people who didn't return to clinics. PEPFAR funded data capturers. Without PEPFAR, it's very, very hard for those districts to keep track of who's on treatment, who isn't. do monitoring and evaluation. And our government also has community health workers, but the NGOs manage them in a much better way. So the money that we got from PEPFAR is responsible for about 17% of our HIV response. The money that comes to South Africa, the country that gets the most PEPFAR funding of all countries, or one of the most, but I'm pretty sure it's right up there among the top 3. And that money comes through either USAID to South Africa or the Centers for Disease Control and Prevention. So what's the situation at the moment is that the USAID programs have been stopped and the CDC programs are still continuing. So it's about 50-50, the distribution between those two federal agencies, but they only have budgets through to September the 30th. So what we've seen is that the first thing that happened that we could see playing out in South Africa when that stop work order came was that the key populations, the men who have sex with men clinics, transgender clinics, sex worker clinics closed down within days. You saw it no longer being there. Then we saw PrEP programs suffering. So again, we buy the PrEP drugs ourselves, the oral HIV, anti-HIV pills, but PEPFAR covers 75% of the costs of getting it to people. So, demand generation campaigns, making it easy to get it from mobile clinics. Some projects actually deliver it at people's homes. So that is something that is now a challenge. But also, so it's not that you can't get it, but it's a lot harder to get. You're going to travel a lot further. And we had a promise of CAP-LA, the 2-monthly anti-HIV injection, to arrive before March in South Africa. It didn't come. So now we won't have long-acting PrEP. And we also had CAP-LA, so again, the 2-monthly injection. We had sites where there are implementation trials to see how best to get it to people. Now, although we have many of those still running, there was one trial that was funded by the by PEPFAR, and they had 6 sites where they could choose between CAP-LA, between the vaginal ring and the daily pill, and they now had to pull all of it back, and they can only have the daily pill now. Now, in addition to that, South Africa last weekend, the National Institutes for Health started to withdraw funding for research. And although that's not foreign aid, it has a massive impact on how much we know about HIV, TB, and how much innovations they would be. So the first cancellation letters started to roll in for a massive trial unit at the University of Witwatersrand that does HIV and TB work. And that grant has now been ended. And there's a leaked memo, which we got hold of at Bhekisisa, but also Nature, the journal, got it, which talks about who wouldn't get research grants in the future. And they list the subjects: climate change, COVID, HIV prevention, and along with that, they list 2 countries of concern: China and South Africa. So it looks like South Africa may lose all its research from the NIH. It's about, there's no specific document that tells you how much, but researchers estimate that if you look at direct and sub-grants, it could be as much as $400 million a year. And if you look at that, then there would be a massive impact on universities in South Africa. And in addition to that, I think we often forget about the mental health impact on the people who worked for those organizations who closed down now, because they work in a field that's basically been decimated now. There's nothing left. PEPFAR, if there's one thing that the Trump administration did make us realize, it's just how much money the United States contributed. And no donor has that type of money to fill the gap. They can fill a little bit of the gap, but not nearly everything. And I know of at least one person, I'm busy with a story on it, who died by suicide because of her job that was lost and the massive impact it had on her. So all in all, I would say key populations, and what makes South Africa situation a little bit more different even is that we have an additional executive order from other African countries. We have one that says South Africa's all the foreign aid will be cut. It doesn't matter for what it is. because President Trump believes we have politics that he doesn't agree with. Our ambassador was sent home about a week ago, and he believes, he spreads division in the country in the sense that he says white Afrikaans people are oppressed, which is simply not true. I'm white and Afrikaans and I live my life here, and I know that's not true, but there is a lot of offspin of that where it causes division, especially against the really divided history that my country has. Jonathan.
Thank you, Mia. I have a follow-up question for you, but before I ask it, I just want to contextualize a bit for our audience. Mia has referred repeatedly to PEPFAR, of course, the President's Emergency Plan for AIDS Relief, the cornerstone of U.S. global health assistance. And of course, in addition to that, in addition to bilateral HIV funding, the U.S. government also funded significant maternal and child health programs, other infectious disease programs, programs to combat some chronic conditions, neglected tropical diseases, strengthening of health systems overall, really quite a vast tapestry of assistance. Yeah, so there are estimates that over the last couple of decades, U.S. bilateral support to health programs in South Africa alone averaged about $400 million a year, if I have that roughly correct. You've started to answer this, but help us wrap our heads around what an amount like that means for a country like South Africa, a sense of the scale and scope, if you could.
Well, Jonathan, if you look at, we have a campaign that the health department has launched. Only about 3/4 of the people with HIV are on treatment in South Africa. And often it's people who've already been diagnosed with HIV who choose not to go on treatment. So to get them on treatment, if you want to stop HIV, you need a lot of community work. You need to get those people to the clinics. That is where the PEPFAR programs came in. They were the programs who were going to find those 1.1 million people. They go into communities and they go and see, and also because they funded data capturers. So it's easy to see who didn't turn up to collect their treatment, for instance. They were the people who would go out into communities and test people for HIV. And as we know, you don't just go out in a community and have a tent and say, come for an HIV test. You need workers who go into the streets and shopping centers and invite people to come. The same with PrEP. As you may be aware, PEPFAR was responsible for 91% all PrEP rollouts in the world in the past 5 years. It was announced at the recent CROI conference, the Conference for Retroviruses and Opportunistic Infections. So in South Africa, that's a little bit lower, 75%, but it's still really, really high. Now, if you look at how do we fill that gap, what do we now do that we don't have that money? So I don't have a clear answer. I don't think anyone has a clear answer. But one certain thing is definitely that the government needs to step up. They haven't yet stepped up with money. We've had our annual budget announced in about a month ago, and there was no special provision made for the PEPFAR programs that lost their money. There's a lot of austerity in our government at the moment. So we need to find ways to do things better with less. And one of those things is also to look at other donors. So we don't just get US government money, we get Gates funding, Wellcome Trust funding, but Wellcome Trust, which is the second largest donor when it comes to HIV funding in the world, or biomedical research funding in the world, the budget of PEPFAR is still 25 times more. So in some cases in South Africa, local donors have come forward, and that's good news. They didn't do these things before. In fact, today I had a call from one local foundation, the HCI Foundation, and the great thing about that is it's the CSI arm of a private company, a commercial company, and those companies weren't traditionally involved in these programs, and they're going to help two PEPFAR organizations, the Innova Health Institute and Wekesa in South Africa, to get some of their funding. But of course, they don't have the budgets that PEPFAR had, but still they will help. thing is, in South Africa, we have a very strong campaign towards universal health coverage, because that's one solution to look at how to get more services to people. But it's a very, very controversial campaign, and there's a lot of doubt in the government's ability to roll it out. But just to give you an idea, in South Africa, we spend about 8.5% of our GDP on health, which is quite high if you look at what other countries spend. But that amount is divided 50% between the private and the public sector. But that's very uneven, because 85% of people rely on the public sector and only 15% on the private sector. So you could imagine how much more is spent on each person in the private sector.
Thank you, Mia. And I want to come back, if and when we have time, for all of you, to this question of the specific value add of US aid in terms of that community work that you mentioned, the key populations, the getting the treatment and testing to people. You also, of course, referenced PrEP. That refers to pre-exposure prophylaxis, daily medication to prevent transmission of HIV, highly effective, and as we heard, the US responsible for the vast majority of it. Danjuma, let's come back to you. We know that although most US global health assistance supported HIV programs, that the impact of this aid stoppage is felt across the entire health sector. Can you give us a sense in Nigeria, where you are, what the impact has been on cuts to programs to address other infectious and chronic conditions besides HIV?
All right, thanks, Jonathan. I would like to say that US aid has gone beyond just HIV and AIDS, for example. I think just some days back, I heard about the cut of funding to Gavi, which supports birth dose vaccination. And then that is going to make a significant impact in stopping new infections, in ensuring that babies get vaccinated at birth. And the PEPFAR support, or the US support, has helped, for example, in Nigeria, in drug supply chain. So hepatitis, we know, has always been underfunded despite the huge burden. Hepatitis is like 254 million people. Nigeria is about 15 million people. But one thing again, Jonathan, that I was telling colleagues the other day, that to be honest, we've always taken for granted, but with this, we kind of, oh my God. So we have all this while benefited from this, but it wasn't very apparent. What is it? The drug supply chain systems that this funding, the PEPFAR, the grant have helped, the HIV drug supply system, procurement systems. And because HIV-B, for example, still uses TDF, which is the antivirals, and most of these benefit from the systems the HIV, sub-funding from the US have helped to put in place. So the risk now is that with the cut in funding, we sincerely don't know what's going to be, but I know for sure it's going to impact on the supply chain. It's going to impact on the availability of TDF for, let's say, mono-infected patients. And we see how patients with comorbidity, right? HIV and hepatitis. So then I think Mia was saying this thing, which has benefited the hepatitis communities. For example, community case managers, helping people retention in care. Funding has helped to put in differentiated models of care, and which we have leveraged those systems to bring relink to care in hepatitis. So with the case managers disappearing from health facilities, with support groups disappearing from health facilities, with the case, with all of these community systems no longer there because of the lack of funding, is making a huge dent, is making a huge impact on the hepatitis programs that we've always taken advantage of. Now look at the integration of hepatitis into antenatal care, maternal and child health care. In the context of triple elimination, hepatitis was leveraging on the HIV systems to do triple elimination. That is eliminating HIV, hepatitis B, and syphilis. And that is most likely going to suffer, because with this cut in funding, because there's no funding for hepatitis. So we're leveraging all these systems of trained healthcare workers, systems in drug supply chain, systems in diagnostics. I cannot, there's because of the lack of funding in hepatitis, we leverage on the viral load, the cepheid, all the diagnosis systems in hospitals. Most likely with the cut in funding, it becomes a problem to hepatitis patients to access those systems. And again, PrEP also is one of the commodities, so one of the drugs some hepatitis patients are placed on, and even including the double combination of TDF and lamivudine. If there is a stock out and if there is non-availability of all of these, hepatitis patients will definitely suffer from this. But as I mentioned, birth dose vaccination is likely going to suffer. I was reading there that US CDC, because US CDC has done a lot in maternal and child health in birth dose vaccination program, and they've done a lot supporting government of Nigeria in supporting systems in vaccination immunization. It's going to be a big problem, Jonathan. In Africa, only 13% of babies had the birth dose vaccines. And if there's a cut in funding, I'm afraid we're going to have children coming out with hepatitis B. And for example, Africa will have majority of young people coming down with liver cancer because we cannot close the tap to new infections. With birth dose vaccine going, it's going to be a huge problem. And research also on the treatment for hepatitis B, which have leveraged on the infrastructure and the HIV systems, is definitely going to be a problem. So these are some of the fears we have. I was just hoping that there will be something, a silver lining. I hope to make sure that the systems come back and there's investment nationally across governments to ensure that the systems pick up and hepatitis programs will continue to leverage on this. But it's a huge gap and a huge problem for the hepatitis community as well. I stop there, Jonathan.
Thank you, Danjuma. Beatrice, I want to come back to you with the benefit of having heard now from Mia and from Danjuma quite a bit of detail about the very specific ways in which African countries have relied on the United States. They've given us a really dramatic and frankly tragic sense of that reliance, right? That reliance for everything from community case managers to procurement and supply chain systems, to, getting to key and vulnerable populations, actually getting the medicines to individuals. I mean, this is the sort of detail, the nature of the reliance. So in light of that, I want to come back to your point about the impact on women. How is it that relying on the United States in that way makes women more vulnerable to the impact of a freeze on aid?
Jonathan, what we know from the history of AIDS, but also what we know is that the patriarchal system is such that all diseases, name it, all diseases burden women, that the role of care is left to women. Taking care of a child, be taking care of a husband, any relative, that burden is on women. So what we have seen in terms of managing HIV and other diseases is that when you go to hospitals, when you are in the communities, it's usually the women that are carrying this burden, whether they themselves are sick or have the issue, they take on that role. Now with PEPFAR, with the funding from the US, particularly with PEPFAR, the women had got some kind of relief in that burden of care by having specialized clinics close to within the communities. We've been having these clinics funded. So in terms of accessing services, the services were nearer to the women. They were in the communities. They could easily go get, maybe if it's there, be tested on their child or relative, and also get the medications that they required. Now, what is happening, and also not it was funded so they could actually get it for free. So what is happening now, the women have to take long distances to the clinic, to the public clinics, and on top of that, out of pocket. And I will use the example of malaria. which we know is the highest, the number one killer in Uganda, for instance, and in many other African countries. It's the disease that kills most of our people. And you'll find that most of the people who shoulder that burden are women, especially pregnant women. And the US has been covering like most costs. The biggest amount, I think the US, what we know is 90% of the diagnostics, treatment itself has been covered by US funding, and the rest of it has been out of pocket from the patients themselves. So with that withdrawal of funding, it does mean that actually the burden now is on the patient, and most of that it's women actually, or the person that takes care of the patient, which is woman. And in the sense that we know that most of these women do not, most of them don't work, they don't have health insurance, most of them do not control finances even in their own homes. So it's such a huge burden on these women. When you look at tuberculosis, it is again the women who take care of most patients with tuberculosis in communities, but also when they are admitted in hospitals, the caretaker will be a woman, which is a common phenomenon in most parts of Africa. And to have these women walk long distances, to leave them exposed to tuberculosis, and most we had managed to contain MDR-TB in Uganda to some extent with the US funding. Now the risk of MDR-TB become an epidemic is very imminent, and the people, and I can assure the people who are at risk most are again the women. So the burden on women, you cannot disassociate the burden of care and vulnerabilities that are associated with US withdrawal of funding. You can't remove women from that the burden. It's the women that are faced this most. When you look at the withdrawal of Gavi funds, it's the women who carry the babies to, first of all, when they are pregnant, they have to be vaccinated, and those vaccines have been covered by US funding. They take the babies for vaccination. They, like until the baby is 1 year, the women are already, you see women crowding public health centers on vaccination days. You'll only see women carrying the babies to the clinics. So again, these women have to find a way of coping and worrying about what is going to happen to their children, worrying about their children having measles or polio, the bulk of diseases, including hepatitis, as Danjuma has shared. All these are burdens that we cannot underscore in terms of what we see happening. And when you look at women again in their diversity, we know the issues of stigma around particular groups of women, the issues of the animosity that which is unfortunate because it's driven now, it is been driven in country like in Uganda, driven by the laws that criminalize particular groups of women and particular groups of populations. Now it's also being driven by the United States. That language that comes from this side, you will actually hear, particularly in Uganda, where I'm more familiar, you will hear people celebrating and saying it is good that now we are not going to have this nonsense of the LGBTQ community. Like there's already the population is stirred up, and people are like, there are pockets of people who celebrate, who do not understand the ramifications of these orders. So it's very unfortunate in the sense that in Uganda we already had that homophobia and the anger from the state itself, driven by the law. And also now when we hear things like the executive order being identified with no more funding for LGBTQ communities. I saw the other day in one of our newspapers, people are complaining about how much funding has gone towards these terrible groups, these evil groups. It is causing a lot of it. The atmosphere is so toxic, and it makes women more vulnerable because of because the society identifies sex work and all that as an immoral thing, and it is again the women that are caught this kind of violence. So, Jonathan, that is the way the situation looks. To be honest with you, the biggest worry about women is because this, at the end of the day, requires money. And we know in Africa that the money economy does not favor women. Thank you, Jonathan.
Thank you, Beatrice. And indeed, I mean, the power of a government to foment hatred and hostility against vulnerable groups is a key part of this that I would invite any of our panelists to elaborate on if you wish. I want to remind our audience that we will have time later in the program for questions to these truly exceptional panelists. Beatrice, while I have you, I want to ask you another question. It relates to a commentary that you wrote shortly after the announcement of the freeze on U.S. foreign assistance. It was published I believe in the New Vision, or in the Ugandan media. A version of it was then republished in the Health and Human Rights Journal. And I think what stood out about it for many of your readers is that, indeed, as our opening speakers pointed to, that your message in that piece was not just directed at Washington, D.C., it was directed at the government of Uganda. And I wonder if you could share with this audience a bit of what that message was.
Thank you. Jonathan, the message is that, yes, we appreciate the foreign aid and the assistance that we have benefited from the US government for years. It's been decades. However, the concern that we have, at least the concern that I raised in that article, is that African governments sat back, that our governments left the obligation of our governments to take care of the health of us as citizens. They kind of like left it to the donors, mostly to the US government. But they forgot, I don't even know whether forgetting is the right word, but they kind of like, they kind of like found themselves so comfortable that somebody else was carrying the burden for them. For instance, when you look at the commitments that our governments made in Abuja, I think it was in 2006, 2005, when our governments, African governments, met at the AU, and they commit to increasing health financing, the budget for health, by 15%, acknowledged and committed that these three diseases were a burden. HIV, tuberculosis, and malaria were bad the health system. And that as a continent, they collectively agreed that they will increase the health budgets of each country to make sure that we're able to get out of this problem, that we squarely address the health issues that we faced as a continent. What has happened until now, and I will use Uganda as an example, the health budget is, the increase is 7%. Since that time, it is only at 7%. And you'll find that our budget has been heavily financed by external funding, that the donors have been funding close to 90% of our health budget. And when you look at the priorities that our governments make, health is not a priority, and that it is left to our donors. And from a human rights perspective, you cannot abdicate your responsibility, your duty as a government, and sit back and you look at and you leave the burden. It's like African citizens belong to the US, that we are the business of foreign funding. For me, that's quite disturbing. And one of the calls that I've been making to my colleagues, and I know, especially when you raise this in Uganda, people are nervous. People do not want to stand up. People are scared because of the brutality of the state. People fear to be harassed, because you'll be beaten up, you'll be bundled up, you'll be misunderstood. But the thing is that we as citizens too should know that we have an obligation to hold our governments accountable. African governments cannot be expecting that they will be beggars all the time, that you leave citizens, you know, like you treat healthcare as a privilege. And the way it is, when you look at Uganda, we have two sets of citizens. We have the struggling citizen, the poor citizen, the one that is abandoned to the mercy of foreign aid. And then we have the privileged class who will procure health at all costs. If it means flying them to the United States or to the UK, and our taxpayers' money is used to sustain that class abroad so that they get the best healthcare they can, it will be. When you look at the priorities this week, I think I was reading last week, because I targeted that article was meant to target the time when the budget is being the budget debate and the new financial is coming up, so that we have that allocation made, so that our legislators can hear our voice and they allocate resources, knowing that we have an emergency. But even with the scale of the problem that we have, you will be shocked to see the Ministry of Finance is prioritizing financing elections, because we are going into the election year next year. They put a huge budget, I forget the amount, but it's in billions, to prepare for next year's elections. And the next item is also to prepare for the African Cup of Nations. That is what they tabled as a priority. And our Speaker of Parliament also made a priority to, she raised the issue of taking care of the former legislators, the ones that were in Parliament before the previous legislators need to be taken care of, especially their funerals. But there should be a budget allocation to cover their funerals. But they are not worried about the implications of what is happening right now. So the key message for African governments is, much as we know that the US has an obligation to global health, African governments need to take up responsibility. They need to be held accountable. And this provides an opportunity to rethink African health, to rethink our health budget, to take care of our citizens as an obligation that our states are obliged to. So Jonathan, the basis of that article for me was to raise accountability and to show our African heads of states that we cannot, as a continent, to rely on foreign aid and treat health as a privilege for the minority of citizens, while relegating the majority of citizens to the mercy of foreign aid. That is where I was coming from. Thank you, Jonathan.
Thank you, Beatrice. And let us all, for a moment, stay on this question of African responsibility, shall we? Which, of course, Bob and Allan framed at the beginning, and which you've specified, Beatrice, is ultimately about African governments' responsibility to their poorest citizens, who have been, as you said, abdicated to the mercy of foreign aid. Mia Malan, I mean, this abdication in the case of South Africa is to the tune of nearly $10 billion in foreign assistance over a couple of decades. How does South Africa begin to reclaim responsibility for this? What are the political prospects of that, in your view?
So I actually have heard our health minister and our president say quite often over the past 2 months that we must find ways to be reliant, and that it's not the US government's job, essentially, to maintain us. So I think in South Africa, the unhappiness has mainly revolved around the way in which it was done, that it was done overnight, not because we think it is someone else's responsibility to maintain us. Of course, something like this, if you say, how do we reclaim it? It highlights ways in which reasons why we don't have money. And one of those reasons is corruption. Money disappears. So it's definitely highlighted, what can we do about corruption, and how can we make our budgets work better for citizens so that all the money gets to where it's supposed to be. What will be interesting to see, one, say, concrete example to see if the government steps up would be, that the HIV world is on the cusp of a breakthrough when it comes to preventing new infections. So over the past, say, 10 years, a little bit more than that, medication has evolved for that you can take, and then you don't get HIV if you have sex, even if you don't use a condom. And that is what Jonathan referred to is the short of that is PrEP. It stands for pre-exposure prophylaxis. It's just medication that you drink before you get exposed to HIV, essentially. Now, there's been a daily pill forever, but that pill you have to take each day. And the problem with the pill is it doesn't work like a vaccine. If you don't take it, it doesn't work. So people don't take it regularly. Now there is an injection that you can take twice yearly. So every 6 months you take this injection. It's called lenacapavir. And in the trial that was actually done in South Africa and in Uganda, it showed that not a single of the young women who took it got HIV. But there is now a test for our government because in December, the AIDS Fund of the US government, PEPFAR, and another fund, a multilateral fund, so a fund to which many governments contribute, the Global Fund. They made an announcement to say they're going to buy lenacapavir for countries like South Africa to start rolling it out. And it's highly unlikely that it's now going to continue to be funded by PEPFAR because the Trump administration has different priorities. So the only way, it's very costly and it's still in the process of being registered with regulators. The only way to really get it to South Africa, a country like South Africa now, is the Global Fund will still contribute, but would the South African government step up and say, we've got data to show us that this could prevent a lot of new infections. In fact, there's a recent study that showed that we could end AIDS as a public health threat if we roll it out widely 10 years before what we thought we would. It looks like 2040 if we look at data that we could possibly make 2030. Now, would our government then step up and pay money? The money that they previously wouldn't have had to pay because there would have been a PEPFAR. So to take responsibility, I think you start with one example and you start with something that has good data that show you that there would be a good return on it. And the return in this case would be to bring down new infections significantly. Politically, I think, when something like this happens, just like COVID, it does speed up solutions because the crisis is just so urgent and you need to come up with the solutions more urgently. And if there's something that I do think South Africa has shown in the past is that it's got a very, very strong civil society and activist community. 2-3 decades ago, when ARVs were unaffordable, South Africa played, I would go as far as saying, the strongest role in advocating for prices to go down and for the government to find ways to afford these drugs. Now, South Africa gets them at very good prices today because of the millions of doses that we buy. We've got 8 million people with HIV. I think we can learn lessons from that and apply them today. And I have seen our HIV traditional activists becoming very vocal during this time.
What a fascinating kind of theory of change toward greater African self-reliance and domestic financing to kind of begin and campaign around a case study. And can injectable PrEP be, in a sense, the kind of antiretrovirals of this moment in opening that up? Thanks so much for that suggestion, Mia. Danjuma, let's come to you, remaining on this question of African responsibility to, as you called it, the poorest of the poor. Of course, traditionally, one of the main arguments against, obstacles to this has been the suggestion that African governments lack the fiscal space to do it, in part because of the supposed debt burden that they face to high-income countries. Mia mentioned that a conversation has been opened up about this. What is your response to that?
Thanks, Jonathan. I think Beatrice and Mia has alluded to some of the points I wanted to mention. Jonathan, each time we go to the World Health Assembly in Geneva, you see African leaders are so good in flying to Europe and high-level meetings, sign up to commitments, put up a lot of media show to ambitious global goals, and they come back to their regions and countries. They don't prioritize health financing. They don't prioritize budgeting, and they don't prioritize political or financial commitment to the laudable, ambitious goals they sign up to. And this is very concerning, and it's very, very disturbing that I think, like Beatrice mentioned, in my country, Nigeria, probably 2027 is just some few years back around the corner. And what they're thinking about is just politics. What they're thinking about is just about the elections. And when this funding aid was announced, the cut was announced, most often leaders in Africa are not always proactive, they're always reactionary. And I think most of the announcements were made are not really sustainable to address challenges that will come up in supply chain, in healthcare worker system, in drug supply, and everything. So I would say that, I would say with all sense of responsibility, that foreign aid has been a blessing indeed. Millions of lives have been saved. I have relatives that are on ARVs. I have people that were undiagnosed with HIV that have been diagnosed now. But in other part, has been a cause to leaders in Africa. One, it has led to dependency and deepened corruption among African leaders. Deepened corruption because budgets are not really made to address healthcare systems. Budgets are mostly misappropriated or whatever for political gain or for other reasons, personal reasons. And like we mentioned earlier, Beatrice also mentioned, they don't go to the local hospitals. Most of the politicians do not access services. They don't go to hospitals where they are told to come back in 3 months because the machines has broken down. So they don't understand what the patients and the communities experience. They don't go to the hospitals where they tell them drugs are out of stock. They can access all top-level high-quality services because of resources. So it's really sad that even the debt, to start with, most of those debt, how were those debt incurred? Unfortunately, most of those debt were not even incurred to finance health systems, mostly projects, construction projects, mostly because, of course, we all know what happens. There's always something that goes under the table in most of those projects they always want to do across countries, in Africa. They do just road constructions, and they will tell you they don't know the value of investing in healthcare. Like Mia mentioned, where there's return on investment. For example, in hepatitis care, for every $1 invested in hepatitis care, you have $2 return on investment. They would rather go and put $1 billion in a road because they know they're going to get some percentage back in one way or the other. So corruption, they do not prioritize the lives. They do not know investment in health. You're having a healthy, productive workforce. You're having a healthy, productive young people. You're having a healthy community. So even some of those debt and those money incurred were not really incurred in the best interest of the citizens. Incurred to run white elephant projects that they just in debt countries to pay debts in 10, 20, 30 years, putting the lives of generations, indebted to foreign countries. So not really because of the best interest of citizens. So I love what Mia mentioned about civic engagement. And I had a call with colleagues some weeks back, and I told them in my state, Taraba, that we need to have a policy brief and a roundtable to begin to tell these leaders that they haven't felt the impact yet. They don't understand yet what's going to happen when the drugs are out of stock, when the volunteers are no longer in the facilities, and they don't even think about it. They're not even doing nothing, And I was saying again, budgets that were passed last year, budgets need to be, modified, adjusted to address the current challenges. They still go back borrowing money from World Bank and other institutions, not to invest in health, but to put up in projects that they have kickbacks, corruption. So it's really sad that even most of the debt, Jonathan, we're talking about were incurred not in the best interest of citizens. not investing in universal health coverage, not investing in vaccine and immunization programs, not investing in training of healthcare professionals, but mostly construction projects because they know they're going to get back their kickbacks. So it's really sad that inclusiveness and accountability is really lacking. And I hope that community groups and patient groups will really rise to challenge these systems and make sure that the leaders are much more accountable. My colleagues have mentioned almost everything about accountability, inclusiveness, and ensuring that our leaders. So I think this is a wake-up call. For example, in the hepatitis community, Jonathan, we're telling ourselves, what can we do differently from what has happened now? What can we do to avert this kind of scenario? So we're looking at public-private partnerships. We're looking at asking governments to do more of local productions, looking at high net worth individuals within countries and domestic financing. We cannot shy away from this. It's time to really begin to shake the tables and hold our leaders accountable to make sure that they're more responsive towards the needs of the citizens. And patients and community perspectives should influence budgeting, should influence health financing, equitable health financing across the regions and across our countries. I stop here for now, Jonathan.
Thanks, Danjuma. And I have one more question about African responsibility that I'm going to pose rather to all of you and ask you each to respond to. Before I do that, I want to flag that after this question, before we go into our final questions, I'm going to extend the opportunity to our co-presenters, to Bob Wekesa and Adam Powell, to ask any questions that they may have, if they have questions at this point, for any or all of the panelists. And then after that, we'll open it up, and I encourage you, you could either turn on your camera and raise your hand, or you could put a question into the chat. So while everyone thinks about questions for this incredible panel, one more question about the African responsibility issue, because you've each spoken so powerfully about not only the need, but also the possibility for African governments to, I mean, this is my word, reclaim their responsibility to guarantee the right to health. My question is, what role, if any, do you think that leaves for the United States and other high-income countries? Is this a collaboration or not? Is there a role for the U.S. government? Does Washington have obligations in the field of African public health in addition to African governments? And if so, what are those obligations? Danjuma, let's start with you.
I think it's well, just in the context of global health security, and then the context of humanitarian aid. So in the context of global security, I think protecting infections, antimicrobial resistance in a small community, my local, is also protecting the populations in the US. And diseases and infections are not just contained in one local community, right? So in the context of global security, I think it's in best interest of the United States to also finance health aid and then to support health systems and then disease prevention across the world. So that is just one aspect of it I'll just mention. Thank you.
Thank you. Beatrice?
Jonathan, the US still has a big role to play here. First of all, we need to think about the fact that this was abrupt, that the US took an abrupt and aggressive decision. The US still has an opportunity to rethink. There's still room to rethink this decision, considering the implications and the effect that this has, not only on Africa, but the potential it has to spread beyond Africa. That epidemics do not have boundaries, that this could actually become a global crisis. So the US should rethink this. Number two, the fact that the commitment by PEPFAR, the commitment to support Africa was already made. that the administration actually needs to recognize the fact that this was a commitment that was made, that there were people who are already on treatment, that there were people who are benefiting from prevention of infections, that an abrupt, the abrupt order that was made is a breach of a commitment, that it has an impact on international cooperation, that trust, like the whole thing about trusting the relationship between the US and Africa is very important. And the other issue is also the US has financial muscle, political muscle. Mention it. We all know that this is the global superpower, that using its influence and the power that the US has, that the US can actually cause an engagement with African governments, especially on the issue of accountability and taking responsibility. That if, as it's perceived, that the foreign policy, that foreign aid is overburdening the United States, that the best decision wouldn't be to abruptly have an order that stops, that has implications, that affects communities that are vulnerable. Instead, we could actually review this and allow a transition plan, that the US can cause a transition plan by engaging African governments and we, the communities that are affected the most, that we can come up with a transition plan with milestones, and the US could continue supporting that transition plan as we also engage African governments to put their houses in order. And I know that this is something that we have done back home before, when we had issues with the group fund. And we, as civil society, we worked so hard to see the Global Fund engage the Uganda government with the transition, with the clear milestones. So we still have that opportunity where the US can actually use its power and voice and financial muscle to prevail over this situation. It is not too late for that to happen. But basically, for me, it would be also to engage our governments to be more responsible, more accountable, and proactive in terms of taking responsibility for the health of citizens, rather than being complacent because there's foreign aid. That's what I would say at this point, Jonathan. Thank you.
Thank you, Beatrice. And indeed, one does wonder why the path of a responsible transition plan has not been taken, but thank you for reminding us that it is absolutely not too late to do that. Mia Malan, what is your vision for the future role of the United States in African public health?
Jonathan, I think if there's one thing that COVID taught us, it is that we don't live in isolation, and that investing in global health is certainly not only about altruism. It's about keeping your own country safe. And that if you don't invest in it, you put your own people at risk. And when it comes to something like HIV, one of the best ways to invest in it is to invest in HIV prevention, because prevention ultimately is cheaper than treatment. I don't think the US government is going to invest in HIV prevention. I think they've made it quite clear with their waiver rules that that's not where they would be going. But I do think that if it doesn't invest, then America's not going to become safer and stronger and more prosperous, because there's going to be so many unpredictable external forces that influences it. And I think probably the best investment that they could make is to invest in preventing disease outbreaks, because that will help the country itself, and it will also help other countries to protect themselves. But at the same time, they will also be protecting the source of funding.
Thank you so much. One can begin to see the contours of a future for global health in your answers. So we are so appreciative. So we have about 30 minutes left. We're going to open it up. I'd like to begin with Adam, with you, and with Bob. If you have any questions, I know we have one question at the table in Washington that we'll come to right after that, and we invite others to put questions in the chat or to raise your hand as well. Adam or Bob, any questions from you?
As they say on Capitol Hill, I yield the balance of my time to the gentlemen and gentleladies of Africa.
Thanks, Adam. Bob?
No, thanks. I think my query to our colleagues who have made such very powerful data-based, evidence-driven presentations is this whole area of indigenous or traditional medicine. The African Union, in fact, has something called African Medicines Agency. In 2023, there was quite a heavy focus, and I think, in fact, annually, there is an African Medicines Day, Traditional Medicines Day. In one of those, in fact, the Chinese partnered with the African Union, drawing on their own traditional Chinese medicine. And I think for most Africans on the call, I suppose many others growing up, I included, when we were growing up, our parents or village mates and so forth will say, if you use this plant, it can help you manage malaria or things like that. Is there any possibility of indigenous traditional knowledge in these fields helping, or is a pipe dream? I mean, I'll put it to you. Thanks.
Thank you, Bob. I think each of you brings different dimensions of expertise to this question. Mia, perhaps this is something you've done or seen reporting on. Beatrice, you've worked in the field for decades. You might have a perspective on this, including on the gender dimensions. And Danjuma, you've raised your hand, so we're going to start with you with this question.
All right, so Bob brought up a very important question, but the challenge about traditional medicines, especially in my field, is the lack of data, lack of science, especially for liver care and hepatitis. There's not so much of the scientific evidence to really portray the need for that, especially for liver care. So we're very careful telling patients to use herbal medications because of the lack of evidence and lack of research and science to support the use of that, especially in liver care. As a matter of fact, it's a problem so much among patients when they go on herbal medications and that aggravates the condition of the liver. So I'm aware of the African Medicine Agency, and the challenge has been about the regulations, right? Harmonized regulations to really make sure that the medicines are available for patients. So, and this also translates to other aspects of lack of evidence and science in the region of Africa. There's not much investment in clinical research. There's not much investment in clinical trials in the region of Africa, especially engaging patients, most especially in the part of liver care. So that is a big gap, and I hope maybe in the nearest future, if there's more investment in trials, in research, in clinical trials in the region, when we have enough evidence and data, we could really, really advocate and encourage patients, people with liver conditions, to take up that point. But for now, we put a lot of caution to patients on herbal medication because of the lack of science and evidence in that regard. Over from me.
Thank you. Mia or Beatrice, anything on this? Mia.
So I agree with Danjuma. I think we need data. I think whether it's indigenous medicine or whatever medicine, we need data, because not only do we need to know that it works, but we need to know that it's safe to take. And it is possible. Like in South Africa, about 10 years ago, there was a plant that the Khoisan people used called hoodia. They used it to suppress their appetites. And that went into clinical trials. And it's a medication today for people who need to lose weight, who have health risks because of obesity, if they have severe obesity. But clinical trials take a lot of time. It doesn't take a year to do, it takes 5-10 years to get that data. and it's very expensive. So before you can start with that, you need to have relatively good indicators that the thing that you're going to test is worthwhile that money. But I think Hoodia is a good example of something that proved to be worthwhile. But absolutely, we need data first, and we especially need to know that the substance that's taken is safe and in what quantities it needs to be taken to be safe.
Thank you. Beatrice, did you want to come in on this question?
Jonathan, at this point, I would say it is something important, but for the kind of emergency we have right now, where people need to continue with treatment, where people need to be protected from infections, where children are at a risk of polio, measles because of the withdrawal of Gavi financing, I think I would be hesitant to have this discussion at this time, because right now it's about addressing an emergency. The other thing also is this would get our government off the hook. For me, the point is to ensure that our governments are accountable, that they actually come up with a contingency plan, that we are seen as a continent to be addressing this emergency before it goes out of hand. That to me is what is critical. The other challenges around data, safety, and all that, these are discussions that we have had, and we have many people who have tried different stuff. During COVID in Uganda, we had a doctor who came up with something to do with some kind of agent which was funded to, to do with COVID and stuff like that. We saw that, but right now, for me, the focus would be to really get our governments to act and not to give them any opportunity for any excuse to get off the hook. Thank you, Jonathan.
Thank you, Beatrice, and thank you, Bob, for the question. So we have a queue of questions forming. We're going to begin in Washington, D.C., and then move to the chat. If your question is for a specific speaker, please direct it to them. And we're going to begin with a question from Ambassador Greta Morris. Ambassador, please.
Yes, thank you very much. Thank you, everyone, for a really enlightening discussion. My question, I'm not going to direct it to any particular person, but whomever has an answer would be great. When the announcement of the end, essentially, of USAID assistance was first announced, a lot of people in the United States said, well, other countries will come in, and particularly Russia and China will come in to try to replace the United States and use it as an avenue for gaining influence in other countries. And I'm just wondering if you have seen any of that in Africa, of other countries coming in, and particularly Russia and China.
Thank you, Ambassador. We're fortunate to have 3 different regions of Africa represented on this panel, and the Russian and Chinese influence will play out differently in different parts of the continent. So I'd like to give each of you an opportunity to respond to this. Mia, shall we start with you?
So no, we have not seen China or Russia come in, even though South Africa traditionally has good relationships with those 2 countries. And I think something to remember when it comes to specifically China is there was such an interesting article in Foreign Affairs, actually a week ago, called The Coming Global Health Crisis, where they spoke specifically about this, would China take over America's role? And the thing with China is it's not interested in investing in, global pandemics or where the urgencies or the need lies, the type of things that the United States used to do. It's really interested in whether it can gain strategic influence or whether it could get minerals from a country. So the motivations behind why they would invest are very different from the motivations of the previous administration of the United States, the reasons for investing, they used data and said, this disease is bad here and this is what we need to do to counter it, where the Chinese investments are driven by other motivations and are also often short-term and not monitored in very extensive ways with data to see if it was successful. And it's very often more in infrastructure than it is in providing medication on the long term or helping with data to analyze a disease and that sort of thing. We'd really encourage people to read that Foreign Affairs article that was authored by Thomas Bolecki and Yanzong Wang.
Thank you, Mia. Danjuma.
Yeah, I think Mia has said most of the things I would love to say. We haven't seen any yet. But then again, possibly those are informations that is always at the highest level of people in government, but at the level of community or in the news media, we haven't heard or seen anything of that yet.
Beatrice, anything you've heard in Eastern Africa about Russian or Chinese influence and how you would see that playing out, as Mia referenced?
Jonathan, I haven't heard anything. There doesn't seem to be any partner coming in to fill that gap. But my feeling is that my opinion on this is that the scale of funding that the United States has been giving to Africa for all those years, talking about decades, is huge. It's enormous. The support to our health system has been so enormous. I mean, I'm talking about in Uganda, where we have close to 90% of our health budget funded by the United States. I was looking at the countries that have been benefiting from this, and about, I think, half the countries in Africa are badly affected by this freeze. So to get a partner, be it China or Russia, or I don't know, whoever, to come in and fill this gap, and we are talking about a gap of decades, I am skeptical that we are likely to get that kind of support from somewhere else. It would be very interesting. Also looking at, again, as Mia says, looking at the trends of China and where their interests have been, I am very, very skeptical that they would invest in something like this. And I would say, you really, where we should intensify our conversation with looking at the United States, looking at a contingency plan and to look at transition, really to ensure that we review this decision, that the US reviews the decision, so that we have a safe transition as we push our governments as Africa to see that the continent takes the bull by its horns. That's what I can say about this, Jonathan.
Thank you, Beatrice. We have a few questions in the chat. So Beatrice, I'd like to stay with you for the first question from the chat. I think it picks up on points that you've made about commitments to spending a certain percentage of African budgets on health. This is a question from Grace, and she is asking, how do we hold the African Union accountable, especially in light of its member states meeting the commitments of the Banjul Protocol, which a majority signed up to, but have constantly downplayed in budget allocation? What are your thoughts on AU accountability?
I think I'm very hesitant to make, sometimes when I'm talking about the AU, I get so emotional. It is so frustrating to see that the AU meets regularly, but they do not take health as a priority. And I know that when the news of the freeze broke out, I think a week later or 2 weeks later, the AU met, I think in Addis Ababa or something. There was a meeting anyway, and this issue wasn't even put on the table. The issue that even when it was an emergency, the issue stuck to what had brought them to the room, and what brought them to that room was elections, to elect the next leader, and they did not see a place of this emergency. That just demonstrates to you how the AU works. They deferred the issue to the African Health Ministers meeting. I do not know when that is happening, but that for me speaks to the level of which the health of African citizens is taken. However, I think that this is an opportunity for us as civil society, as communities, as African activists that are concerned about this, to document what we are seeing, engage the EU even before they have their meetings. We have an opportunity to meet, I think, the new commissioner or something. I don't remember, the Raila Odinga was given a position recently. We can begin to meet people like that, and also to look at who among them really sees value in what we are speaking. Because I believe that some governments have taken this on. I have heard, is it Danjuma, is it Nigeria, your side? I've heard different presidents speak. I've also heard the Burkina president speak on the issue. I do not know him that well because he's quite new, but we can look at those governments that seem to be doing something, or who have interest, who like appear to be concerned about health. I don't know how it is for you, Mia, your end, but we can begin to lobby the different leaders that we think will listen to us, because I don't believe that the entire AU, that all of them are adamant about this. I think within them, we need to map out and single out those that we think can listen to us, and we engage them. We don't even need to wait. This has to start now. Thank you, Jonathan.
Thanks. I have other questions I want to direct to Danjuma and Mia, but anything specifically on the AU you want to share in response to Beatrice?
Yeah, let me just chime in. Beatrice, the greatest challenge you and I face is that who opens the door for you to even see the AU leaders in their meetings? They so are not inclusive. In fact, advocacy, rights-based advocacy in Africa is so difficult, Jonathan. It's very difficult to attain. You shake the tables, and I mean, the inclusiveness, engagement of civil society voices. In my country, Nigeria, it's easier for me to see my Minister of Health in Geneva than to see him in Nigeria here. And even the AU meetings, I'm not sure how inclusive they are to open the door for civil society and patient groups or community groups to even engage them, right? And what you said is exactly what some of us were like saying. That thing happened after the announcing and it was not even on the table. Yes, I think I heard my Nigerian president did mention that, but how do they follow up to really make sustainable decisions is where the challenge is. So, but I think it's good that we begin to build collaborations and maybe storytelling op-eds, or maybe in one of those, maybe at the health assembly, whatever it is, to really do one or two things. Some little bit of activism, I believe, maybe might touch the head and the heart of some of the leaders.
Mia.
No, I don't have much to say other than I think the AU should stick to its commitments to to progress local manufacturing of medicines in Africa. You know, that's been such a big thing, and without that, we're going to get nowhere.
Thanks, Mia. So while we're on the subject of Pan-African responses, which I think we could have a whole session on, there is a question in the chat about the COVID-19 Africa Vaccine Acquisition Task Force, which of course was a Pan-African team that during COVID was able to procure vaccines at better terms, as well as bring in conversations about generic medications with largely successful results. And the question is, and maybe Danjuma, I can bring this back to you because you talked a lot about vaccines and procurement systems and supply chains, as well as about the AU. If you have a point of view about it, the question is whether this is an approach that could be considered by regional economic communities going forward, perhaps relaunched, not just for COVID.
Yeah, Jonathan, the major issue we have especially is the fragmentation in terms of even the regional blocks or the systems within Africa. And that I think was it Bob who mentioned earlier about the African Medicine Agency. There is so much issue around fragmented kind of regulations and systems to get drugs, vaccines, right, to countries and then to regional. So the lack of harmonization of either vaccine access or procurement is a big issue within Africa. But yes, I think that was the success of the COVID vaccine is really something we could take up. And I think it's high time we really bring in the high net worth private individuals, public-private partnerships to drive this within Africa. I saw someone did mention somewhere there about high net worth individuals within Africa. We have the billionaires, they have foundations, but we've not been able to succeed to get to what really touches their hearts and their head, to commit towards financing, making pledges to support systems within Africa in terms of financing. So I think harmonization of these systems will be the best way for us, and getting this commitment from public-private partnerships will be the best for us within the region. Over from me.
Thanks. So the question about billionaires that you referenced specifically named South Africa and Nigeria. So I'm going to stay with you, Danjuma, and also come back to you, Mia, for this very provocative question that Kabaso has put into the chat. And what she notes is that South Africa and Nigeria have some of the highest number of billionaires on the continent, yet their private sectors, in her view, have not significantly stepped in to fill health financing gaps. So in your view, what structural or policy changes might stimulate greater private sector investment in African health systems, especially with declining external aid? Mia, let's start with you and then go to Danjuma.
Well, during COVID in South Africa, we did see a lot of private sector investment. We had a fund called the Solidarity Fund, and business in South Africa came together to manage that fund and to donate to it. So what policy changes, I'm not so sure, but what I can say is a crisis, certainly fighting for the same thing, certainly make people forget about the things that they disagreed on, and then they come together. So maybe a crisis like this, could be the beginnings of it. I've seen 2 private foundations investing in health that didn't do it this way before, helping organizations who lost their funding with, small contributions compared to the American government contributions, but still quite large for what they did previously. I just want to get back to the issue of the African Medicines Agency. It's one thing to say, let's have a mechanism to procure medicines for Africa, but no one can use those medicines if it's not registered in their countries. And we really do in Africa need an agency, just like the European Medicines Agency, where registration can be done in an easier way for countries and in a cheaper way. Some African countries don't have medicines regulators. So I think if there's one thing we really do need to invest in as a continent, it is the African Medicines Agency, so that we can get to a point where there's sharing of data and where the process of registering the medicines is sped up.
Thank you, Mia. Danjuma, would you like to take the question about Nigerian billionaires?
I think maybe some little bit of taxing, maybe some little bit of putting basic financing funds, like Mia said. I was in a meeting somewhere in Kampala, and I think was it in Uganda or some one other country that gave example of 2% of all contracts for road constructions go to health financing. So maybe it's a little bit more of taxing these billionaires and making it more of really taxation. I think might probably, because it's difficult to get them, Jonathan, it's difficult to get to talk to them. They put in a lot of, and again, making some of them ambassadors, maybe through high net worth individuals, and maybe through some high profile government individuals might work. But I think policy changes could maybe some little bit of taxation, creating some basic funding mechanisms, maybe some percentage of the construction projects or contracts should go into health financing and commodities procurement, maybe locally. That may be probably might be able to help.
Thank you. There is one more question in the chat about telemedicine and mobile healthcare. And Beatrice, I'd like to direct it to you because I think it resonates with comments that you made earlier about women in particular having to travel long distances as they assume a larger care burden, which will intensify with the stoppage of aid. So this individual is asking, what do you think is the role now and into the future of telemedicine or mobile medical units to reach out to the most vulnerable populations to sort of bring the hospital to the patient, as it were? Is that something that you see a role for in Uganda?
Yes, Jonathan, this mobile clinics could work, and that has been happening actually. We have always had mobile clinics, but again, funded by external donors, mostly by the US, where we have had, like we have rural communities where there's no hospital, no specialized care. So we have been having like community outreaches, like on day X, the mobile clinic for HIV/TB will be in this area, and people are sensitized in the community, so they know that particular day, and that has been happening. So the team comes, they do the screening, they do the if people need their refills, and all that is done. Cervical cancer screening, everything done in the community. So we know that works, and that is the very thing that has been taken away. In terms of telemedicine, I think that would have limitations to people who can use smartphones, who have that access. More so, people who have a place to charge their battery, like have their phone fully charged, which is not easy in most rural areas. Maybe for the small phones, what we can get is, say, text messages and stuff like that. That can work. During COVID, this was also done, and it worked so well because of the restrictions of movement. People could get, a few of our colleagues would pick medication for their friends and actually take it to their homes. It did work, but it was mostly personal, individual initiatives, not supported by the government or any other support. If this is well supported and funded, it can actually work. It would relieve the burden on the most vulnerable people, like women, the groups that are marginalized, particularly the women with disabilities, the women who have to move with maybe a baby on their back. This would be very helpful if it's explored and also funded. Okay, thank you.
Thanks so very much, Beatrice Were, Mia Malan, Danjuma Adda. Thank you all for your just terrific, outstanding interventions on this topic of grave concern. Thanks, of course, to Job Allan Wefwafwa and Bob Wekesa for framing the remarks. And I have the privilege of turning it back to Adam Powell to announce our next program and conclude today's session. Adam.
Thank you, Jonathan. And please let me join you in thanking all of our speakers and all of you who joined us online and in person in Washington, D.C. Our next program will be Monday, May 5th at this same time, World Press Freedom Day, Views from Africa. And I would imagine we're going to have some views that go well beyond journalism and information and address civil society. So Monday, May 5th, World Press Freedom Day, Views from Africa. And we hope you'll all join us then. Until then, we're adjourned. Thank you for coming.